Hello everyone, I'm Anas Al-Ubaidi. I'm Anas Al-Ubaidi. Hello everyone. And the topic or the title for this session, for this lecture, is Integrated Patient Cases, Neurological and Sensory Disorders. It is within Chapter 29 of Review of Neurology and Ophthalmology Scribing within the Certified Medical Administrative Assistant Course Program by ACMSO. Introduction. Integrated patient cases, neurological and sensory disorders present a compelling learning opportunity for advanced medical scribes. These cases embody the intersection of neurology and sensory systems, such as vision, hearing, and proprioception, demanding a nuanced understanding of how these systems work together and how their dysfunctions manifest. For medical scribes, documenting cases involving these complex interactions is both a technical and intellectual challenge that directly impacts patient outcomes. Neurological and sensory disorders often present with overlapping symptoms. For instance, dizziness may stem from a vestibular issue, a neurological condition like multiple sclerosis, or MS for short, or systemic causes such as anemia. Sensory deficits like double vision or hearing loss might similarly trace their origins to an array of pathologies, including nerve damage, strokes, or even simple mechanical obstructions. Accurate documentation is indispensable in clarifying the origins of these symptoms, guiding clinicians toward effective diagnostic and treatment pathways. Missteps in recording the onset and progression of symptoms, physical exam findings, or imaging results can lead to misdiagnosis, delayed treatment, or suboptimal patient care strategies. The management of such integrated cases often mandates a multidisciplinary approach. A patient presenting with tinnitus and dizziness, for example, may require input from an or otolaryngologist or otolaryngologist, neurologist, and audiologist. Another patient displaying hemianopia and hemiparesis may necessitate collaboration among radiologists, neurologists, and rehabilitation specialists. Medical scribes serve as the nexus in these scenarios, ensuring that diagnostic impressions, test results, treatment plans, and interdisciplinary discussions are cohesively documented. Their work, the medical scribes, directly supports continuity of care by creating an accessible and well organized record that clinicians or providers can use to monitor progress and adjust care plans accordingly. One of the biggest challenges in documenting these cases is the sheer breadth of factors that must be considered. A patient's complaint of sensory deficits could involve everything from a detailed history of exposures or trauma to extensive diagnostic investigations, such as brain MRIs, auditory brainstem response tests, or nerve conduction velocities. Each piece of data holds significance, and the ability to synthesize and record this information in a way that is both concise and comprehensive is a skill scribes must master. Neurological and sensory disorders also often require long term management and follow up care. For example, conditions like Parkinson's disease or diabetic neuropathy necessitate ongoing adjustments to therapy as well as regular monitoring for progression or complications. Similarly, sensory disorders such as age related macular degeneration or sensory neural hearing loss may involve adaptations to a patient's lifestyle and environment over time. Effective documentation serves not only as a roadmap for current interventions but also as a living record that tracks the evolution of the patient's condition. enabling more informed uh, decisions at every stage of care. Furthermore, medical scribes play a pivotal role in high stakes scenarios such as acute strokes or neurological emergencies involving sensory loss. These cases demand immediate, flawless documentation of key metrics like the last known well time, imaging results, and administered therapies. Properly structured and detailed records are critical not only for the patient's safety and management but also for meeting legal and ethical compliance standards. Key points: comprehensive symptom documentation. Integrated patient cases often require meticulous documentation of symptoms to guide diagnoses and treatment plans. Documentation must include all relevant details about the onset, nature, and progression of both neurological and sensory symptoms. Here we have the onset and progression of symptoms, key elements to record, precise timing, minor, sudden, or gradual onset, and progression of symptoms, for example, worsening, stable, or episodic. Example here, we have sudden onset of vertigo and unilateral hearing loss at 7 p.m. while sitting upright. Importance here provides critical context for differential diagnoses such as peripheral vestibular disorders versus central neurological causes like stroke, brain stroke. Detailing sensory deficits, here we have key features document specific impairments in vision, hearing, proprioception, or touch, include associated complaints like pain or numbness. Example: right hand numbness with a burning sensation progressively worsening over 3 days. Significance here helps narrow down etiologies such as peripheral neuropathy in diabetes or central causes like spinal cord compression. And here is a summarized diagram on breaking down syndrome symptom documentation. Characterization of neurological issues. Components here include abnormalities in movement, tremors, paralysis, cognition, memory loss, confusion, or specific sensory symptoms, visual field loss, hypersensitivity to touch. Example: hemiparesis noted on the left side, accompanied by slurred speech and facial drop. Usefulness here facilitates immediate recognition of emergencies like stroke or the gradual progression of conditions like ALS, amyotrophic lateral sclerosis. In identifying triggering and relieving factors, details to note environmental, physiological, or psychological triggers, relief methods such as medications or positional changes. Example: pain and dizziness worsened by head turning to the left, alleviated by sitting still. Value clarifies patterns typical of vestibular pathologies or neural compressions. Documenting cognitive and emotional impacts, focus points, insomnia, mood changes, and anxiety or other psychosocial interactions that overlap with the neurological and sensory symptoms. Example: patient reports heightened anxiety accompanied by stabilizing headaches and tinnitus. Why it's critical: provides insights into mind body relationships and disorders such as migraines or fibromyalgia. And here is a summarized diagram on triggers and relief methods. Diagnostic standards and tools for neurological and sensory cases. Here we have as the effective use of diagnostic tools is integral to resolving complex patient cases. Scribes must understand how to document results clearly and concisely. Neuroimaging findings, key data here, record abnormalities identified on MRI, CT scans, or PET scans in a clinical relevant format. Example: MRI of the brain reveals punctate ischemic lesions in the right parietal region. Impact here helps evaluate structural problems like strokes, tumors, or demyelination typical of multiple sclerosis. Functional testing here details to capture results of audiometry, vestibular function tests, for example, VNG caloric tests, and evoked potential studies. Example: audiogram shows sensory neural hearing loss bilaterally worse in the left ear. Clinical use here differentiates among conductive hearing impairments, vestibular dysfunction, and central causes. Electrodiagnostic studies focus areas here include nerve conduction studies, NCS, electromyography, EMG, and their findings. Example, EMG findings suggest axonal neuropathy in the ulnar nerve distribution. Relevance here identifies nerve degeneration versus inflammatory processes. Laboratory results supporting diagnosis. Essential data here capture relevant lab findings from blood tests, for example, inflammatory markers, B12 levels, or cerebrospinal fluid analysis. Example, elevated CSF protein level consistent with Guillain-Barré syndrome. Importance augments imaging and functional assessments in complex cases. Clinical examination results details to include reflexes, muscle tone, cranial nerve function, and their abnormalities. Example, absent corneal reflex on the left-sided trigeminal innervation. Utility forms a foundation for diagnostic hypotheses in neurology uh, clinics. Handling complex integrated cases, patients with overlapping neurological and sensory deficits present unique challenges. Documentation must reflect a comprehensive understanding. Multifactorial symptom overlap. Approach integrates symptoms across systems to theorize interactions or causes. Example, dizziness, nausea, and double vision following a traumatic head injury. Benefit unifies disparate complaints to explore multifaceted diagnoses. Example, traumatic brain injury or labyrinthine dysfunction. Prioritization in acute events, focus points here document critical times, interventions, and early impressions for immediate care. Example, acute vision loss in the right eye, last vision noted normal at 1 p.m., Doppler shows right carotid stenosis. Outcome, guides rapid diagnostics and life-saving interventions such as thrombectomy. Chronic care documentation, key need here track progressive disease impacts on therapy outcomes. Example, over 6 months, patient shows progressive gait instability and tremor worsening, unresponsive to levodopa. Purpose adjusts long-term management in conditions like Parkinson's or Huntington's disease. Addressing psychological and quality of life concerns, documentation must um, capture effects on daily functioning and emotional well-being. Example, patient reports inability to work due to tinnitus, considers cochlear implant evaluation. Why it matters highlights psychosocial elements for multidisciplinary care plans. Adverse event monitoring focus here recording new or worsening symptoms, unintended medication side effects, or therapy failures. Example, patient on carbamazepine reports severe fatigue and blurred vision, adjusted dosage to 200 milligram daily. Benefit promotes proactive management and early mitigation of complications. Supporting multidisciplinary care, collaborative documentation of complex cases ensures effective communication and care team coordination. Emergency and acute setting collaboration, key role here records swift diagnostic findings and specialist consultations. Example, otolaryngology consulted for vertigo, audiometry confirms vestibular dysfunction. Impact prevents missed critical elements during acute phases of care. Rehabilitation coordination, documentation focus, monitor progress in motor, sensory, or cognitive recovery. Example, rehabilitation notes improvement in left hand grip from 2/5 to 4/5 in 4 weeks. Purpose tracks outcomes and informs next rehabilitation phases. Integration of specialist input focus on aligning neurologists' notes with input from ENT, radiology, and rehab professionals. Example, neuro ophthalmologist rolled out optic nerve involvement in persistent diplopia. Result provides comprehensive care tailored to the patient's needs. Chronic disease teams Key elements: collaboration among endocrinology, neurology, and primary care for systemic causes. Example, diabetes-induced peripheral neuropathy. Example, neurologist recommended pregabalin, endocrinologist adjusted insulin regimen for better glucose control. Outcome improves patient management and mitigates complications. Long-term planning and referrals. Critical notes here document referrals to palliative care, ongoing monitoring, or advanced imaging recommendations. Example, follow up with audiology in 3 months scheduled to evaluate worsening sensory neural hearing loss. Benefit strengthens support for future symptom evolution and management. Summary table. Here we have table on key elements for symptom documentation in neurological and sensory disorders. We have symptom, critical details to document, example, clinical importance, risks if not documented. Symptoms, we have vision loss, hearing loss, dizziness slash vertigo, numbness slash tingling, gait abnormalities. We have table on diagnostic standards and interpretations in neurological and sensory disorders. Test, key data to document, example, relevance, risks if not documented. Tests, we have MRI slash CT imaging, vestibular function test, auditory brainstem response, EMG slash nerve conduction studies, ophthalmologic exam. Here we have table on documentation for complex integrated cases. Case type, components to document, example, importance, risks if not documented. Case types, we have traumatic brain injury, stroke, sudden hearing loss. Continuing with this table, as case types, we have multi-system disorders, syncope slash pre-syncope. Table on documentation in multidisciplinary care for neurological and sensory disorders. Scenario, key teams and collaboration points. Example, value, risks if poor documentation. Scenarios, we have rehabilitation cases, stroke, follow-ups. Continuing on scenarios in this same table, chronic sensory symptoms or syndromes, surgical neurosciences, vertigo slash dizziness cases. Then we have table on compliance and standards and documentation. Compliance focus, essential documentation elements, example, benefits, risks of non-compliance. Compliance focus, here we have HIPAA and privacy, ICD-10 and CPT coding. Continuing with compliance focus, we have diagnostic justification, emergency responses, objective and legible notes. Then we will revise what we have covered through this lecture via some multiple choice questions or MCQs. Question 1. Which detail is most critical to document for a patient experiencing sudden vision loss? A, the patient's occupation. B, the exact time of symptom onset. C, the patient's preferred method of communication. Or D, the patient's diet on the day of the episode. Definitely it's B, the exact time of the symptom onset, as the exact time of symptom onset is vital in determining medical interventions, such as whether a patient qualifies for time-sensitive treatments like thrombolysis in stroke cases. Question 2. What is the primary focus when documenting a case of progressive bilateral hearing loss? Is it A, the patient's speech patterns? B, the severity, progression, and triggers of hearing loss? C, the patient's financial ability to purchase the hearing aids? Or D, the patient's childhood medical history? Definitely it's B. The severity, progression, and triggers of hearing loss, as precisely documenting severity, progression, and triggers provides clarity on whether the loss is sensorineural, conductive, or mixed. This informs treatment directions such as audiometry tests or ENT consultations. Question 3. When handling an acute stroke case, which documentation element is essential? A, patient's highest academic qualification. B, last known well time and NIHSS score. C. Number of family members attending the appointment. Or D. Past medication allergies unrelated to the current condition. Definitely, the most reasonable answer is B. Last known wall time and NIHSS score. As recording the last known wall time and NIHSS score is vital to evaluate eligibility for interventions such as TPA or thrombectomy and to quantify stroke severity. Question 4. Which factor is least critical to document when evaluating a patient with dizziness? A. Whether the dizziness worsens with specific head movements. B. Results from the Dix-Hallpike maneuver or other positional testing. C. The brand of footwear the patient was wearing. Or D. Associated symptoms like nausea or visual disturbances. So, least, definitely C. The brand of footwear the patient was wearing, as the brand of footwear is irrelevant in neurological documentation for dizziness. Crucial details focus on positional associated symptoms or test findings to determine vestibular versus central causes. Question 5. How does multidisciplinary documentation benefit chronic sensory and neurological conditions? A. It reduces the need for ongoing evaluations in chronic cases. B. It ensures consistent input from specialists to align care plans. C. It focuses care entirely on one symptom at a time. Or D. It keeps patient records accessible solely for to neurologists. It is B. The answer is B, as multidisciplinary documentation consolidates input from various specialists, ensuring aligned and comprehensive care plans for complex conditions like diabetic neuropathy or multisensory deficits. And here we come to the end of this lecture. Thank you very much and goodbye.